Hello, everyone. Thank you for joining us for New Health Partnerships, Improving Care by Engaging Patients. My name is Julie Schills, and I'm a co-chair for the Center for Multi-Stakeholder Demonstrations. My other partner co-chairs are Sherry Erickson from the ACP, John Swanson from the AAFP, Sally Bleeks from Blue Cross Blue Shield Association, and Guy Mansudo from FITEL. We're excited to have this presentation today. The Center for Multi-Stakeholder Demonstrations' sole purpose is to disseminate information that's important regarding patient-centered medical home. We try and create an environment in which everyone can share lessons learned and new opportunities with each other. I want to remind everybody that Patient-Centered Primary Care Collaborative will be having a stakeholders meeting on July 22nd. And if you haven't had a chance, please check out our new website. It has been updated and provides a wealth of information. Our session is being recorded today. The PowerPoint and the presentation will be available on the website. I wanted to let you know that we will have poll questions throughout the presentation. And at the end of the presentation, I'll be looking through as you have questions and you type them into the chat room. We'll be spending about 10 minutes at the end of our presentation going through some of those questions. So without further ado, I want to introduce Dr. Doriane Miller from the University of Chicago Medical Center, as well as Judith Schaefer from the McCall Institute. Dr. Miller and Judith Schaefer are leaderships with the New Health Partnerships. They've really built much of the work through other partnerships around self-management and creating a collaborative framework in which patients and families, as well as the healthcare providers, have that relationship that they work together. And we have found, and I know in our work on a daily basis, that intimate relationship and collaboration truly supports effective patient care delivery. So with that, I will turn over the microphone to Dr. Doriane Miller.
Julie, thank you so much for that introduction. I'd like to share with you this afternoon both the background and findings of a national demonstration that was funded by the Robert Wood Johnson Foundation and the California Healthcare Foundation on ways in which healthcare organizations can introduce self-management support into the clinical setting by including patients and families in the planning of those demonstrations. I was the National Program Director for New Health Partnerships, Improving Care by Engaging Patients, and Judith Schaefer also worked with me as the Director of our Learning Collaborative. On our next slide, there's just a slight description there of the objectives for our talk today. We'll be providing you with an operational definition of CSMS, which is Collaborative Self-Management Support, and we'll demonstrate a little bit of the efficacy, the evidence for efficacy of implementation of self-management support, and to demonstrate its context in patient-centered care. We'd also like to talk with you a little bit about the role of self-management support as a quality improvement strategy. And importantly, we'll be giving some examples of its influence on system redesign, patient outcome, and the business case for improvements in chronic care self-management and chronic care management in the outpatient setting, and also some information about some tools that you may be interested in trying in your own day-to-day practice. So, an operational definition of collaborative self-management support, and this information comes from the Institute of Medicine. Self-management support consists of collaborative goal setting and shared decision-making between patients and doctors, includes regular follow-up to monitor and assess the patient's progress towards goals and relating those plans to the patient's social and cultural environment, and also tracking and ensuring implementation, including linking support programs to the individual's regular source of medical care and making sure that we monitor those pieces and their effect on the patient's health. The evidence base for self-management support is the following. This is an example of a study that was published in the Medical Care Journal in 1999 on the Stanford Chronic Disease Self-Management Program. It was a 6-week program that was conducted with a group of patients that had a number of conditions, including congestive heart failure, arthritis, chronic lung disease, and stroke, in order to look at ways in which patients could improve their ability to manage their chronic health conditions on a day-to-day basis. It was found during this particular study that there were improvements in the cognitive symptoms of patients who participated in the chronic disease self-management program with less health distress, better communication with providers, and importantly, fewer hospitalizations, and also for those patients that were hospitalized, fewer days in the hospital. 2 years later, they followed up with a longitudinal study of the patients who participated in the 6-week chronic disease self-management program and found that patients were able to maintain the gains of reduced emergency department visits and hospitalizations, and importantly, from the patient's perspective, an improved quality of life. The next slide shows a picture of the chronic care model, which is used for implementation of the work that we've done within this demonstration on self-management support, with a reference to a study that was conducted by Dr. Thomas Bodenheimer and others, published in the Journal of the American Medical Association in October 2002, in which they looked at the 4 core elements of the chronic care model, namely self-management support, delivery system redesign, decision support, and clinical information systems, and its impact on the improvement of outcomes for people with diabetes. Within this particular meta-analysis, 19 out of the 20 interventions that were associated with improved either processes or outcomes of care for patients with diabetes included self-management support interventions. And so although we've talked about things from a more general perspective with the work of Dr. Lorick, and now specifically around diabetes, the application of this within the context of the chronic care model can be applied to other conditions as well, such as asthma, congestive heart failure, and others. And in fact, it's the application of these 4 core components that you can see, along with the addition of senior leadership from the healthcare system perspective, and also linkages to community resources and support that can help to provide productive interactions between patients and providers, leading to improved health outcomes. Now, the question that you may be asking yourselves at this point is that if we've got great evidence in the literature, not just from these 2 studies, but also other studies, why is it that this isn't being implemented on a broader basis within practice? There's a provider lack of awareness and skills in terms of implementing self-management support, and frankly, some providers doubt about the effectiveness of it, and that isn't it just enough to provide my patients with information through patient education, a few pieces of literature, and to go home, as opposed to actually sitting down and going through the process of shared decision-making and collaborative goal setting. Rush practitioners don't sometimes follow the established practice guidelines that are associated with evidence-based practice around improvement of care, and then lack of care coordination, and that refers to the extension of care and care services beyond the clinical setting. Lack of active follow-up to ensure the best outcomes is something that's a very critical piece of implementation of self-management support, and oftentimes when I speak about this, it's in the framework of self-management support being not an event that you check off on a checkoff list in a flow sheet, but actually a process of care that helps to better establish relationships between the patient and the provider. And then finally, patients being inadequately supported to manage their illness on a 24/7, 365 basis. The program that we implemented through New Health Partnerships was taking the planned care model or chronic care model that I showed a couple of slides ago and looking at that model through the lens of self-management support. And so in planning for this initiative, we worked with Judith Schaefer and her colleagues of the Sandy McCall Institute of Group Health Cooperative in Seattle to say, what would this look like if we took this and essentially took the model and showed it through the prism of self-management support? What kinds of designs and redesigns would be necessary in order to help drive improvements in self-management support in the ambulatory setting? These are the principles that we came up with in order to show what pieces of the planned care model needed to be improved in order to help to drive clinical improvements through the self-management support lens. And that is delivery system redesign, making sure that we could deliver efficient and effective clinical care and self-management through mechanisms that many of you may be familiar with, such as group visits, such as care management services that take place through the clinical setting. The importance of provider decision support and patient decision support, which promotes self-management support with both scientific evidence and also patient preferences. And this goes along the lines of the definition that I provided you with earlier, which is looking at collaborative goal setting and shared decision making based on the socio and economic and cultural factors of the patient. Clinical information systems, the ability to organize patient and population data to facilitate self-management support. That is, it's a process, not an event, and you need to be able to track not only what's been done, but also the outcomes. A healthcare organization and senior leadership that promotes a culture and mechanisms that promote self-management support. And then finally, the linkage to community in order to mobilize community resources to promote self-management support for people with chronic health conditions. This may take place with voluntary health organizations, faith-based community, or other mechanisms, but ways in which you can actually extend self-management support outside of the clinical setting. We conducted this work through several learning collaboratives, and today I'm going to discuss the results of two of those learning collaboratives that took place between 2003 and 2006. The two learning collaboratives lasted between 7 to 11 months and included 26 teams that were fairly heterogeneous, including rural and urban teams. There was a fairly large ethnic mix. Some of the teams decided to take on projects that were condition-specific, and others took on ones that were cross-cutting. We also had projects that were involving patients that were in safety net settings where the patients were either on Medicaid or were uninsured, and also in private commercial fee-for-service settings. We asked our teams to focus on core competencies of self-management support, namely collaborative goal setting and shared decision-making, along with the systems redesign pieces, clinical information systems, and also community linkages as proposed through the chronic care model, and also asked them if they were interested in taking on the business case. In addition, we also asked our teams to include patients and or patient family members not only as recipients of care, but actually in the planning process of the demonstrations that were done in these communities. Our Quality Allies Learning Community worked with another Robert Wood Johnson initiative, which developed the Primary Care Resources and Support Survey in order to determine whether or not they were able to actually implement the changes that we had suggested along the lines of goal setting, a system for documenting self-management support services organized as an organizational support measure, and also the integration of self-management support into primary care as another organizational support measure for the demonstration. We were able to show that in comparison with baseline, and the survey that the results that you see here are for the sites that participated in our second learning collaborative that compared to baseline, that both their patient support scores and their organizational support scores went up across the board in all domains that were measured with a statistically significant comparison between baseline and follow-up. In terms of the content results for both of the collaboratives 1 and 2, we were able to find that we had robust practice models for adoption and replication in a variety of settings. We were able to demonstrate a business case for implementation of self-management support, both in the safety net and also in the fee-for-service setting. And in a little while, I'll talk about the fee-for-service setting business case, which I think you might find of interest, and then also the importance of patient and family involvement. And at this point, I'm going to turn over to my colleague, Judith Schaefer, who's going to talk a little bit more about the actual day-to-day training of self-management support in the practice setting and a little bit of information around tools. Judith?
Thank you, Doriane. Well, I think this slide is probably one that many of you may have seen, but I think it still evokes a strong appreciation among many of you who are practicing in the primary care setting today. A lot of clinicians are feeling like hamsters in a treadmill and that you're just running faster in order to stay still. So we know as researchers and innovators that the results of the wheel going faster is probably a reduction in quality of care, and it's certainly a reduction in professional satisfaction and causes burnout among primary care docs and our staff. So I'm wondering at this point how many of you, just to see, how many of you are already involving some activities for self-management support in your setting. I'm going to introduce a poll. There. So if you would please, you can select any one that applies or any of them, all of them if they all apply. I'm wondering if any of you are using any visit preparation activities or tools. Ask Me 3 is a very common, well-known one in which may be mailed out or used in the waiting room for patients to help them think about what they might want to ask their clinician. Some of you may be using goal setting or action planning processes or tools that help you prepare patients for the visit. And some of you may use visit summaries or care plans that patients can take home. And I see before me that a lot of you have voted already. 36 use some sort of preparation activity or tool. 57 at this point use goal setting or action planning processes or tools, and 38 use visit summaries or care planning. So we can see still that that goal setting and action planning tools are still the heart of self-management support. Even though these other activities are important, I think that clinicians by and large consider setting goals with patients and following up on the action plans, helping them plan carefully, are activities that are the most common among clinicians so far. I'm going to close that poll and go on to the next slide. This diagram is the 5 A's. We looked at several memory devices or helpful aids to help people in primary care practice conceptualize self-management. This probably you're familiar with the 5 A's or 4 A's of tobacco cessation counseling. But this one has been kind of expanded in order to take into consideration the behavior changes that need to go, that need to be used for a more complex set of behaviors for chronic care management. So the first item is assess. At the top of the screen, we want to make sure we know what patients are believing about their illness, what they understand about their illness, and what their preferences and values are around their illness. Then as clinicians, we can offer them advice around specific information on their health problem and the management of their health problem, and also advise them about what they can do to change and how they can improve their ability to diminish the impact of their disease on their daily life. The agree portion is central, and yet it may be one of the most difficult ones. To marry that notion of a treatment plan, the things that clinicians know are important for patients to do, and yet collaboratively work with patients to introduce their priorities into the goals that are set for the next period of involving patients in more actively managing the changes that they make day to day. Typically, the assist portion of the 5 A's is often done by people other than the primary care physician or nurse practitioner. Often this can be done by other nurses or even MAs in the practice setting, thereby offering the clinician more time to work on the treatment plan and collaboratively setting goals. And then arranging follow-up is an important part, not only that the patient feel that they have continuity of care and that they can expect to see their clinical team in a preset time, but also that there may be other activities or connections in the community that might be arranged for them as well. This tool is a very commonly used tool. We call it the bubble diagram. This is a specific, this diagram is specific to diabetes, but there are tools very similar to this that are that can be more generic in character or be specific to other disease conditions. In remembering that many patients have more than one condition, sometimes it's very helpful to have a more generic form. However, on any form like this that's used in just as a tool to introduce the notion of priorities and patient priorities in terms of behavior change, we always leave some blank cells available so that the patients can write in or suggest areas that are of greater priority to them that they want to consider when thinking about what they'd like to focus on for the next period. So goal setting, that's more like an agenda setting tool or a way to begin a conversation about behavior change. These can be distributed before the visit or can be brought out during the time of the visit to just move the conversation along in terms of determining what patient priorities are. And of course, this is probably the most generic action plan. This particular form comes from Kate Lorig's work with the Chronic Disease Self-Management Program, but it has been adapted widely with many kinds of additional pieces of information on it, contact information, follow-up plans. You see the follow-up plans there. But it's been adapted by many centers. And of course, it points to some of the specifics that are so important in helping patients actually make changes. Setting goals is one thing, but making sure it's something that a patient is truly interested, wants to do, is dedicated to do, those are the kinds of things that will determine a patient's motivation and help assure that the action plan is an appropriate one. And then, of course, describing the specifics of the plan, how, what, when, where, and how often. Anticipating barriers and plans to overcome barriers to help patients think about these things before they become tripped up as life intervenes in any person's plan. Using conviction and confidence ratings with patients is a very helpful tool to help you as a clinician understand whether the plans that you're making are appropriate or not. First, to assess conviction about any specific area of change that you and the patient have talked about, and determining whether they're convinced that that is an appropriate and helpful place to start, whether they think that that's going to make a difference in their life. And then once you've focused in on a particular activity or goal, using the confidence rating from 1 to 10 to assess whether you have supported the patient enough in making an action plan that they feel confident they can manage. And then, of course, setting that follow-up plan, call or the next visit, following up with a patient within particularly within a shorter time frame. Often the optimum is 2 weeks, just a brief call to check in with a patient to see how that action plan is going, and offering support in problem solving to make sure that they are able to progress. And here's the conviction or importance ruler. So you might use this simple ruler and just say, how convinced are you that it's important to monitor your blood sugars? And you can ask this, of course, before as you're discussing what you use, what area of behavior change that you're working with the patient on. And if you use the follow-up questions, what makes you say a 4 rather than a 0? Or what would it take for you to move from a 4 to a 6? The answers to these questions provide the context in a patient's life and their beliefs and their thinking that help you offer suggestions and support them in changing their action plan so that it will be more effective and assure them that they'll have a success. Because, of course, it is the incremental progress towards these goals and feeling that success and the emotional support in that success that prepares patients to take on greater goals and work towards a healthier life. This graphic is one of the culminating products that came from our series of 3 learning communities. We understand that there were certain tools that clinical teams were using, and we also understand that they made certain changes in the practice, in their practice team, in order to effectively deliver these self-management support interventions. So we tried to capture, for people who are just beginning this process, what this might look like as a cycle of self-management support. One of the early lessons that clinicians take great solace in is that we aren't expected to do everything at once, that we should think about the cycle of self-management support as an opportunity to intervene repeatedly with patients, supporting them over time in gradual behavior change and improvement in their management. So when you consider things that the precious time that you have during a visit, and it's such a small percentage of the time that patients, or that we're intervening with patients compared to the time they're on their own and managing, we want to assure that we have the information before the visit to make the visit as efficient and effective as possible. So we want to gather clinical data and patient experience data so that we have information from both the medical perspective and the patient's experience. Then during the visit, we want to build relationships starting with the front office. We can offer them tools to, as we mentioned before, to explore needs and preferences, such as Ask Me 3 or how did you do on your action plan. The teams use a variety of tools to help open up this conversation. Then during the provider exam, using these evidence-based interventions, agenda setting with the patient to make sure that you consider their ideas as well as your own treatment plan, to review both the clinical and patient experience information during the visit, and then collaborate to set self-management goals, documenting them in a care plan so that anyone involved in working with that patient will have access to the information that's documented there. And then usually best with a warm handoff so that the provider would, the clinician, the primary care provider would introduce a nurse or an MA or other person who has more time to spend creating that specific action plan, assessing barriers, and supporting that patient in their efforts to change and improve their management ability. They can also do clinical education and skill building if that's within their scope of practice, and make the self-management support action plan become a more specific document that a patient can then take home and use to follow up. And then, of course, where patients and their families live in the community is where a lot of these self-management support activities happen. So peer programs that Doriane mentioned earlier, developing community linkages. We like to say community partnerships because the most effective ones are, of course, not just items on a list of things that we know are available in our community, but partner organizations that we've cultivated in the community so that we know that their education programs or their fitness and nutrition programs or their health promotion programs that are faith-based or other community-based programs are appropriate and helpful to our patients. And building those partnerships can really be an amazing support to patients in feeling supported 24/7, 365. Of course, we always want to know what happened at specialist referrals, so coordinating care referrals is an important part of that process. And just following up with a patient, finding out how they're doing, how their action plan's going, and problem solving. Actually, helping patients problem solve is a very central component of self-management support. So this graphic is a central graphic representation of what is also contained of a toolkit which we devised, which also contains a list of specific high impact changes that you can, that people who have, or practices who have not engaged in self-management support can begin at any point. They can choose one of these high impact changes that appeals to them and get started just as patients do when they're beginning behavior change strategies. Choose something that appeals to you, get started, and see how it works. It also gives the big picture cycle of self-management support. It frames each of the issues that was pointed to in the graphic and offers links to tools that are available on a number of healthcare websites, URLs, and both documents, PowerPoint presentations, tools that you can use with patients, and also gives some scripting to introduce clinicians to new ways to begin different kinds of conversations that help patients change behavior. So as we worked with encapsulating our work in supporting self-management, we found that there were these three things, these three strategies that teams used. Self-management support is definitely, oops, I didn't mean to do that. I meant to go. So teams found, primary care practices found that it's important to create a team because even if that team is comprised only of the primary care clinician and their MA or receptionist in their office, sharing activities and getting support, helping every member of the team support patients in the way that they can according to their scope of practice is an important way to make efficient use of time. Having a shared care plan, documenting action plans and things so that we have a reliable way of tracking not only the clinical parameters but the patient prospective parameters as well in that care plan, and then doing that follow-up care and providing community linkages. So you are all involved in the implementation of medical homes, and I'll bet that you think perhaps a big group hug may not be much of a remedy for some of the problems that you may be encountering in implementing practice changes, just as patients encounter problems in the implementation of behavior change. But using your practice team effectively to their optimal scope of practice can be in a very effective way of implementing not just self-management support, but of course the patient-centered medical home as well. Now I'd like to launch the second poll. I'd like to know which members of your practice team are already engaged in new roles that provide self-management support. So if you could indicate on the screen which of what staff members that you are already engaging in enhancing roles. Wow. Oh, that is amazing. Most of you are working with LPNs or RNs in some way. About 38 or 40% of you are working with front office or reception staff. A lot of you are using medical assistants in new ways. Not many folks have access to behavioral health specialists yet, but there are a third almost have health educators. That is really amazing and wonderful. Thanks for that. It's really encouraging to see people embracing the sense of team and really enhancing the satisfaction of their clinical team members as well. So a clinician that we know of in Michigan, Dr. Christine Sinski, thinks that there are two really important guiding principles when working with patients in a patient-centered way, and we think this applies to self-management support as well. She wants patients to know that they, the practice team, we know who you are and we're going to be ready for you when you come, and that there are face-to-face healing relationships, ongoing healing relationships that happen between patients and clinicians, between patients and nurses, between nurses, and between physicians and their nursing staff, in her case nursing staff. But I think this points to building an infrastructure in which is relationship-based, which involves our patients and their families, but also in the practice team that supports information flow and the human relationships that make primary care practice patient-centered. I'm going to very quickly go through the teamlet model. This is a work of Tom Bodenheimer, who has laid out the mechanism by which a primary care clinician can utilize medical assistants or others to do the action and planning and follow-up. There is a practice team in Olympia, Washington that has really done a lot of work in this area. This is the slide that they utilized to talk about how they used to feel about patients coming in, quickly being roomed by the medical assistant, zooming through the doctor's intervention, leaving with their prescriptions, their referrals, their instructions, and feeling like, whoosh, they came in, they were gone, they were out the door. And what really happened anyway? So as they began to look at an integrated medical plan, which they said includes SMG, which is self-management goal setting, they decided they needed to use other patients, in this case a man and his daughter, and that the provider would still have a role and the medical assistant would have a role, but they would all be enhanced. The first key service they added was a planned visit with the MA. Their patients come in a week early and have a planned visit with the MA just to make sure everything is, that all the information for the clinical team visit is assessed beforehand and is recorded in the chart, and that there's also a time to follow up and do goal setting and problem solving around any problems with a prior action plan. Then when they come in to see their clinical team, the provider uses what they call non-directive counseling. And because this is diabetes, they use this mnemonic device, BBSWAR. They call it the Big Bad Sugar War. And this helps them remember that they always need to get the background, the context within the patient. I did it again. I'm clicking on the names. The background within which the patient's life is lived and what's happening in their lives, what barriers and successes are they experiencing, what is their willingness around this change, around other change, making sure they do an action plan, and remembering always that it's really all about the relationship. That's their that's the helpful mnemonic device that they use, that clinicians use in working with patients. They use two kinds of group visits, both mini group visits, including 2 or 3 patients right in the clinical exam room, or these large open access, open office group visits in which many patients come. And the primary goal is eliciting and answering questions and giving patients an opportunity to share what they're doing and learn from each other. You might want to consider how a patient moves through your practice, and what are the tasks that any team might want to include, both the clinical tasks in reviewing patients' clinical prognosis and also how they're doing in their self-management activities. These flow charts help patients and help clinical teams actually work harder to understand who needs to do what and take accountability for these activities. Doriane, I'm going to turn it over to you now to talk about Mercy Clinics in Iowa.
Judith, thank you so much. So we promised you to give you a little bit of background around how one of our demonstration sites within the initiative actually were able to demonstrate that there was a business case, and specifically a positive business case for the implementation of self-management support. And so we're going to talk a little bit about Mercy Clinics in Des Moines, Iowa, and their implementation of this project. The background that you have there is that it's a collection of 27 clinics with 140 physicians, 70% of whom were primary care, and a little less than 800,000 patient visits in fiscal year 06. They're 100% fee-for-service practice, and they function as a virtual private practice with all revenues and expenses tracked to individual doctors, with the difference of that being the doctor's salary. The Mercy Clinics group decided to, if I could have control of the pointer, please. Thank you. The Mercy Clinic group decided to introduce the concept of a population health coach, a nurse, registered nurse background, who focused in the areas of health behavior change, shared medical appointments, medical adherence issues, focused on training them into Plan, Do, Study, Act methodology, and also focused their area on diabetes management, health literacy, and depression screening. In addition to that, they were also responsible for maintaining a disease registry, looking at the patient's lab and doing a pre-visit with a review of labs and a chart, as well as self-management support, care coordination, and quality improvement. The Mercy clinics used a self-management support encounter form in order to document the activities that were taking place. Now, you'll notice on this self-management support encounter form that they used the structure of the 5 A's of self-management support that Judith described in her earlier comments in order to document the patient's goal or agenda, the patient's readiness to change through assess, what the patient's doctor was advising them to examine around the care of their diabetes, and then some options for behavior change, emphasizing personal choice, readiness and importance and confidence, and also dealing with resistance. In addition to that, they also looked at arranging follow-up for the patients in order to monitor the patient's progress on the behavioral change goals that were set. If you'll notice at the bottom of that form for Mercy clinics, down in the shadows, that they have a little asterisk there that looks at follow-up contact. Mercy clinics was able to work with their Blue Cross provider, Wellmark Blue Cross, in order to develop some pay-for-performance guidelines in the implementation of self-management support, which helped to generate a positive business case for the implementation of this program. Throughout the pilot that they ran on their providers that worked in the area of diabetes, they looked at both process goals around the measurement of hemoglobin A1C, LDL, systolic blood pressure, microalbumin, and also direct retinal examinations for their providers over that period of time, and also some outcome goals around hemoglobin A1C, percentage of LDLs in control range, and also percentage of systolic blood pressures. The providers that were analyzed in this particular pilot, 10 providers plus a 1.6 FTE equivalent of health coaches, so essentially almost 2 nurses worked with this group of 10 providers, looked at the number of diabetes visits that were billed at the level 4 level and weighted average charges compared with 2003 through 2006 where the coach was introduced, and then looked at the charges that were associated with those visits, and they were actually able to find a net differential when the coach was introduced for the year of 2006 of a little over $76,000. On the next slide, in the terms of the North Clinic financial summary for this particular pilot, they were able to generate revenues based on level 1 office visits that were actually done by the nurse coach coordinators, pay for performance work which was pre-negotiated with Wellmark Blue Cross, along with the E&M visit and lab differential of a little over $250,000. The amount of money that they ended up spending on the health coaches, the in-office microalbumins and hemoglobin A1Cs totaled a little over $87,000, and they actually had a positive contribution to overhead of a little over $163,000. Many of the providers who worked in this practice were very afraid that this was actually going to be a net loser in terms of the implementation of the health coach program, protocol and the counseling that took place with patients. But actually, it was a win-win all the way around in that the third-party payer was very happy that they were actually meeting their process and their outcome goals around diabetes. Patients were ending up with better care, and the providers were adding to their bottom line. And so with that, I'm going to turn things back over to Judith, and she's going to talk with you briefly about the shared care plan, and hopefully at the end we'll have a couple of minutes for questions.
Thanks, Doriane. I'm going to be very brief. We just learned that documenting a patient's story as well as the clinical parameters of a patient's care is really important when we're talking about involving them in the activities that really help them manage better. So a continuity, a history, an acknowledgement of their part of this is really important. So you see there the picture of the clinician and a patient working together at the computer screen. But also we'd like to consider, what does that screen say? And this is avant-garde. We're not there yet. But someday we hope that there is going to be a shared care plan in which the patient's hemoglobin A1C is there of record, a recent one of record, but also how did they do with their walking club experience. And we would hope that there would be an acknowledgement of the role and efforts of all members of the care team, and that might be specialists in terms of the primary care team. It might include some specialists, but it also should include what Aunt Margaret contributes to this patient's care, and can be determined by the patient and their family in terms of indicating to the care team who is important in their life and adds to, and they consider important on their care team. And lastly, if the clinical goal is to really reduce blood pressure, we will also want to understand what is important to that patient in terms of well-being and feeling involved in life. And frankly, my marimba classes are more important right now than most anything else. They're not only exercise, but they make me happy. So those are the kinds of ideas we'd like to include in a shared care plan of the future. The one we know now that is, the closest one we are aware of is PatientPowered.org. It is a web platform, and you can go to it. The URL is there for you. You can Google Patient-Powered, and you will find them. There's also a website called Patients Like Me that's indicated here. And, of course, there's the whole notion of Health 2.0 and access to increasing medical and self-management information that's provided by clinical teams and other organizations that are trusted sources. So I'd like to just close by saying that we would really encourage you to look at these 3 sites in terms of the first one includes the toolkit. It is our New Health Partnerships website and includes the toolkit that we looked at earlier. ImprovingChronicCare.org has a number of helpful areas in which you can learn about implementation of team-based care and self-management support. And if you are interested in beginning to involve patients and their families more in the improvement and quality in health care, you will be very well served by going to FamilyCenteredCare.org, which is the website for the Institute for Patient and Family-Centered Care. So with that, I'll say thank you very much and ask if anyone has questions. And Julie, will you moderate those questions for us?
I will. Several of you have questions regarding whether the presentation will be available, and I want to let everyone know that both the recording and the presentation will be available on the PCPCC website. That is www.pcpcc.net, and those will be available by the end of the week. One question that came through is that this work is new to some folks in practices, and do you have any advice in terms of training that's effective for team members in the practice to be able to learn new skill sets around self-management support?
Judith, why don't you take that one?
Glad to, Doriane. Training is helpful, and of course motivational interviewing training can be had in a number of areas. And motivational interviewing you can access resources in your area by simply going to the motivational interviewing site. You can find it on Google. It's very easy. Our toolkit offers a variety of resources for training. There's a whole section on training in the New Health Partnerships toolkit. But I'd also encourage you to think about starting small, looking at what one activity or tool you might begin with, and getting going to see how it works in your team. Often teams want to begin and they think of it as a huge endeavor and don't know where to start, and so spend months looking for just the right training opportunity. So we would encourage you to begin small, just as you would have your patients encourage your patients to start somewhere with a small step. And I think the toolkit can lead you in that direction. The toolkit has many, many connecting links to help in both the behavior change area of self-management support and implementation models and mechanisms that help you get the work done in your clinical team.
Just a brief addition to Judith's comments around training opportunities, and this has more to do with the general application of quality improvement and implementation of the planned care model and day-to-day practice. For those of you who are familiar with the Institute for Healthcare Improvement, they offer both online tips and resources as well as national conferences, the National Forum in December and also the Clinical Office Practice Summit in March, that's geared towards beginner versus intermediate versus advanced applications of quality improvement mechanisms in the clinical office practice setting.
Thank you so much. Another question, I think it was Judith who mentioned following up with patients once a shared care plan and has been developed, following up, say, in 2 weeks. Have you seen some best practices within the practices about how they have set up their systems to be able to have either a tickler system or some mechanism or a role or responsibility to do that type of follow-up?
Yes. It's very often the MA, the team that I highlighted from Olympia, Washington, does utilize the MAs in that capacity as well. So very often the person that does the action planning with patients does the follow-up as well, because the activities are very much the same. However, you know, that person may have clinical expertise or more or less clinical expertise, and so would be able to handle a larger or smaller array of tasks. So the person who does that and their competencies, their scope of practice, of course, determines just how much they can do. But often the behavior change support can be handled by any team member. However, the follow-up is often a very difficult thing for clinical teams to find time to do. However, setting aside a certain amount of time for the MA or others to make that call makes a lot of sense, because it typically is what familiarizes patients with the ongoing cyclical practice of setting goals, trying them out, encountering problems, solving around those problems, and then and the idea that behavior change is an ongoing part of their clinical care. So as these practices, as self-management support activities become more mature in the practice, these follow-up calls become very quick. They don't have to be lengthy calls. And then, of course, the follow-up can also be done programmatically or in a group. So a behavior change plan can be set, and if there are resources like the Chronic Disease Self-Management Program in that community, and if the practice has a relationship with the providers of those or provides them themselves through the clinical team, then there's an opportunity to follow up with patients in a group setting, which may be more efficient and also may help help patients get more input from their peers. I hope that
Thank you so much. I will say that in Colorado, we do have Healthier Living Colorado, which is a Kate Lord self-management model that practices are tapping into, so it's been a wonderful resource for the practices to have. Another question has come through, and it is a billing question, and the question is, can MAs bill for the pre-visit planning office visit, and if so, what code might they use?
The Olympia practice does bill for the MA visit at the lowest level of visit, and the doctor checks in with, looks in on that visit that happens prior to the visit with the doc, is overseen by the clinician, and so they do bill for that visit, but at the lowest level.
Great, thank you so much. Well, I'm looking, and I don't know if Doriane or Judith, if you have any questions or any insights you'd like to share.
This is Doriane. Just a general comment about the importance of the patient-centered primary care collaborative coming together and addressing these issues. The kind of revolution that's going on in healthcare right now really requires partnerships between our payer sources, insurance companies, patients, and providers in order to assure the best health outcomes possible. And I think that the work that you're doing through the Patient-Centered Primary Care Collaborative is designed to address these particular issues in a very comprehensive fashion. And so I just applaud you on your educational efforts.
Thank you so much. And with that, we have one final question that has come in under the wire. It is a question that says, can you describe what you mean by the clinical looks in? And it's, I believe it's
I think they're referring to the MA visit.
The MA pre-office visit.
Yes. I think the clinician reviews any activities that there are standing orders that the MA uses to prepare for the visit, and there is a curriculum that they've been trained to use with patients in behavior change. So the activities that they do can be done initially on their own, but the clinician will check over any of the orders or labs that have been set up, and they will also check in on the visit at the MA visit to assure that the patient, that the clinician is there and is overseeing the activities of the MA. But that need not be a long process. They will simply greet the patient, review what's happened during the MA visit, and sign off on any changes or needed activities, labs, or whatever.
Thank you so much. Well, with that, I think we will close our webinar. I want to thank both Dr. Doriane Miller and Judith Schaefer for joining us on the call today. Their work and effort with New Health Partnership has been impactful in many practices that I know I happen to work with, as well as others that are on the call today. And we so appreciate the focus on self-management and the patient-centered approach. Thank you for sharing your expertise and wisdom with us today. And a reminder that this presentation, as well as the slides, will be available on the Patient-Centered Primary Care Collaborative website. That is www.pcpcc.net. Thank you.